Hello dear friends, welcome to PharmaGrid. So in this session, we are going to discuss about anxiolytic and hypnotic drugs. So anxiety is an unpleasant state of tension, apprehension or uneasiness. Uneasiness in the sense a fear that arises from either a known or an unknown source. We all might have experienced this condition at least once in our life. So the physical symptoms of severe anxiety are similar to those of fear, such as tachycardia, sweating, trembling and palpitations, and involve sympathetic activation. Sympathetic activation, we know that it involves the fight and flight response. Then mild cases does not require treatment, but severe, chronic, debilitating anxiety may be treated with anti-anxiety drugs. These anti-anxiety drugs are sometimes called as anxiolytics or can be used some form of psychotherapy. Because many anti-anxiety drugs also cause some sedation, they may be used clinically as both anxiolytic and hypnotic. Hypnotic agents means sleep-inducing agents. Okay, so sedative agents are the drugs that reduces excitement and calms the subject without inducing the sleep. They act slowly. Whereas the hypnotic drugs are the drugs that induces or maintains sleep similar to the normal arousable sleep. They have got quicker onset and shorter duration of action. So the main difference between sedatives and hypnotics is that sedatives will not induce the sleep, whereas hypnotics induces or maintains the sleep. Sedation is characterized by decreased anxiety, motor activity and cognitive acuity, whereas hypnosis is characterized by drowsiness and an increased tendency to sleep. Okay, so let's have a discussion about the classification of drugs that comes under anxiolytic and hypnotic drugs. The two most important classes of drugs that can be used as sedatives and hypnotics are benzodiazepines and barbiturates. Okay, so let's first see about benzodiazepines. Benzodiazepines can be classified based on the duration of action as long acting, intermediate acting and a short acting. Long acting means they have got a long half-life of about 1 to 3 days. Examples include chlordiazepoxide, diazepam, flurazepam, nitrazepam, quazepam and clorazepate. Then intermediate acting, they have got a half-life of about 10 to 20 hours. Examples include alprazolam, clonazepam, istazolam, lorazepam, oxazepam, clobazam, temazepam. Next is short acting. Short acting, they have got short half-life which is about 3 to 8 hours. Examples include triazolam and midazolam. Okay, so next is the barbiturates. Barbiturates can also be classified as long acting, intermediate acting, then ultra short acting based on how quickly they act and how long their effects last. Then long acting in the sense they act for about 1 to 2 days. Example include phenobarbital. Then intermediate acting acts for about 3 to 8 hours. Examples include pentobarbital, secobarbital and amobarbital. Next is ultra short acting that acts within 20 minutes. Examples include thiopental and methotrexate. So the two most important classes of drugs that can be used as anxiolytic and hypnotic drugs are benzodiazepines and barbiturates. These benzodiazepines can be classified based on their duration of action as long acting, intermediate acting and short acting, and barbiturates can also be classified as long acting, intermediate acting and ultra short acting based on how quickly they act. Other than these benzodiazepines and barbiturates, there are certain other drugs that can be used as sedatives as well as hypnotics, which includes non-benzodiazepine hypnotics, examples including saliplon, solpidem, esopiclone, then melatonin agonists such as ramilton and tazimilton, other anxiolytic drugs including antidepressants, buspirone, meprobamate, other hypnotic agents such as antihistamines, doxepin, suvorexant. Suvorexant is an orexin receptor antagonist. Then melatonin agonists such as ramilton and tazimilton. Then flumazenil is a benzodiazepine antagonist. Benzodiazepine antagonist means it can be used as an antidote for benzodiazepine poisoning. Okay, so let's first see about benzodiazepines. Benzodiazepines are widely used anxiolytic drugs. They have largely replaced barbiturates and meprobamate in the treatment of anxiety and insomnia because benzodiazepines are generally considered to be safer and more effective. Though benzodiazepines are commonly used, they are not necessarily the best choice for anxiety or insomnia. Certain antidepressants with anxiolytic action, such as the selective serotonin reuptake inhibitors, are preferred in many cases, and non-benzodiazepine hypnotics and antihistamines may be preferable for insomnia. Coming to the mechanism of action of benzodiazepines, the target for benzodiazepine actions are the GABA A receptors. GABA A means gamma aminobutyric acid receptors. So what is this GABA? GABA is the major inhibitory neurotransmitter in the central nervous system. So the GABA A receptor is a member of the ligand-gated ion channel superfamily of the receptors. The GABA A receptors are composed of a combination of 5 alpha, beta and gamma subunits that span the postsynaptic membrane. For each subunit, many subtypes exist. For example, there are 6 subtypes of the alpha subunit. So what this GABA will do? The GABA will bind to GABA A receptor. It will trigger an opening of the central ion channel allowing chloride through the pore. The influx of the chloride ions causes hyperpolarization of the neuron and decreases neurotransmission by inhibiting the formation of action potentials. We know that if we are taking a resting cell, the charge inside is negative. If there is more entry of chloride ions, what will happen? It will lead to hyperpolarization of the neuron and thereby reduces the neural excitability. So GABA is a major inhibitory neurotransmitter. The GABA will bind to its GABA A receptors that will lead to opening of the chloride ion channel. So there will be more entry of chloride ions into the cell. It will lead to hyperpolarization of the neuron and thereby reduces the neural excitability. So this is how the GABA acts. So now what this benzodiazepines will do? Benzodiazepines modulate GABA effects by binding to a specific high affinity site that is distinct from the GABA binding site located at the interface of the alpha subunit and the GABA subunit on the GABA A receptors. Okay, so this benzodiazepines will act on the GABA receptor chloride channel complex and potentiate GABAergic action. It will facilitate or it will potentiate the effects of GABA by increasing the frequency of chloride channel opening produced by the GABA. Okay, so the binding of GABA is enhanced by benzodiazepines resulting in greater entry of chloride ions. So the benzodiazepines increase the frequency of channel openings produced by GABA. Also, they can act as a positive allosteric modulators of GABA A receptors. Okay, so the main mechanism of benzodiazepines is that they will potentiate the effects of GABA by increasing the frequency of chloride channel opening. Here we will see a schematic diagram of benzodiazepine GABA chloride ion channel complex. Here we are taking 3 scenarios. So in the first condition, the receptor is empty. There is no agonist. Okay, this is the GABA receptor. The empty receptor is inactive and the coupled chloride channel is closed. Okay, so here the chloride channel is closed. Take the next condition, that is receptor binding GABA. GABA binds to the receptor. So what will happen? The binding of GABA causes the chloride ion channel to open, leading to hyperpolarization of the cell. So in the first case, the GABA has not binded to the receptor, and the second case, the GABA binds to the receptor. Okay, so the binding of GABA causes the opening of the chloride channel and more entry of chloride ions into the cell. That will lead to hyperpolarization of the cell. Now let's coming into the third case, that is receptor binding GABA and benzodiazepine. Okay, so this is the third case. Here the GABA has binded to the receptor and also the benzodiazepines. Benzodiazepines binds to a site other than the GABA binding site. Okay, so the binding of GABA is enhanced by benzodiazepine resulting in a greater entry of chloride ions. So what this benzodiazepines will do? Benzodiazepines will potentiate the effects of GABA by increasing the frequency of chloride channel opening. Okay, so more and more chloride ions get enter into the cell. So entry of chloride ions hyperpolarizes the cell, making it more difficult to depolarize and therefore reduces the neural excitability. Okay, so this diagram is very helpful to understand the proper mechanism of action of benzodiazepines. Okay, so the benzodiazepines increase the frequency of chloride channel opening and thereby potentiates the action of GABA. Okay, now let's have a discussion about the pharmacological actions of benzodiazepines. The first one is reduction of anxiety. Okay, so at low doses, the benzodiazepines are anxiolytics. They reduce anxiety by selectively enhancing GABAergic transmission in neurons having the alpha-2 subunit in their GABA A receptors, thereby inhibiting neuronal circuits in the limbic system of the brain. Second one is sedative or hypnotic action. All benzodiazepines have sedative and calming properties, and some can produce hypnosis. Hypnosis in the sense artificially produced sleep at higher doses. The hypnotic effects are mediated by the alpha-1 GABA A receptors. Third one is the anterograde amnesia. Anterograde amnesia means temporary impairment of memory with use of the benzodiazepines is also mediated by the alpha-1 GABA A receptors. The ability to learn and form new memories is also impaired. Next is the anticonvulsant property. This effect is partially, although not completely, mediated by alpha 1 GABA A receptors. The fifth one is muscle relaxant property. At high doses, the benzodiazepines relax the spasticity of skeletal muscle, probably by increasing the presynaptic inhibition in the spinal cord, where the alpha 2 GABA A receptors are largely located. Baclofen is a muscle relaxant that is believed to affect GABA receptors at the level of spinal cord. Okay, so the pharmacological actions of benzodiazepines include reduction of anxiety, sedative and hypnotic action, anterograde amnesia, anticonvulsant property, and a muscle relaxant property. Next is about the therapeutic uses. The first and foremost one is anxiety disorders. Benzodiazepines are effective for the treatment of anxiety associated with the panic disorder, then GAD, that is generalized anxiety disorder, social anxiety disorder, performance anxiety, and extreme phobias such as fear of flying. It is useful in treating anxiety related to depression and schizophrenia. Because of their addictive potential, they should only be used for short periods of time. Okay, so these benzodiazepines are controlled substances. Okay, so because of their addictive potential, they should be used only for short periods of time. Long-acting agents such as clonazepam, lorazepam, and diazepam are preferred in patients with anxiety that require prolonged treatment. Then for panic disorders, alprazolam is effective for short and long-term treatment. So the treatment option for panic disorders is alprazolam. The anti-anxiety effects of benzodiazepines are less subject to tolerance than the sedative and the hypnotic effects. Next use is for the sleep disorders. Benzodiazepine hypnotics decrease the latency to sleep onset and increase the stage 2 of non-rapid eye movement sleep, that is the REM sleep. Both REM sleep and slow wave sleep are decreased. Short-acting triazolam is effective in treating individuals who have problems falling asleep. The risk of withdrawal and rebound insomnia is higher with the triazolam than with other agents. Why? Because triazolam is a short-acting benzodiazepine. Its half-life is very short. So because of this, the risk of withdrawal and rebound insomnia is higher with the short-acting agents, especially triazolam. Intermediate-acting temazepam is useful for patients who experience frequent awakenings and have difficulty staying asleep. Then temazepam should be administered 1 to 2 hours before the desired bedtime. Long-acting agents such as flurazepam is rarely used due to its extended half-life, which may result in excessive daytime sedation and accumulation of the drug, especially in the elderly. In general, hypnotics should be used for only a limited time, usually 1 to 3 weeks. Non-benzodiazepine agents are now preferred due to reduced potential for tolerance, abuse, and physical dependence. So these long-acting agents are rarely used as hypnotics because of their hangover effect and also due to their daytime sedation and accumulation of the drug, especially in the elderly. Next use is amnesia. The short-acting agents including triazolam and midazolam are often employed as pre-medication for anxiety-provoking and unpleasant procedures such as endoscopy, bronchoscopy, dental procedures, and angioplasty. They cause a form of conscious sedation, allowing the patient to be receptive to instructions during these procedures. Midazolam is a benzodiazepine used to facilitate anterograde amnesia while providing sedation prior to anesthesia. So anterograde amnesia means temporary impairment of memory. So the benzodiazepine, the short-acting benzodiazepines that can be used to facilitate anterograde amnesia is midazolam. Next use is for seizures. Benzodiazepines elevate seizure threshold. Clonazepam is occasionally used as an adjunctive therapy for certain types of seizures, whereas lorazepam and diazepam given by the intravenous or rectal route are the drugs of choice in terminating status epilepticus. Due to cross tolerance, chlordiazepoxide, clorazepate, diazepam, lorazepam, and oxazepam are useful in the acute treatment of alcohol withdrawal and reduce the risk of withdrawal-related seizures. Okay, so these benzodiazepines can be useful in treating seizures and also for the treatment of alcohol withdrawal and reduce the risk of withdrawal-related seizures. Next is for the muscular disorders. Diazepam is useful in the treatment of skeletal muscle spasms and in treating spasticity from degenerative disorders such as multiple sclerosis and cerebral palsy. Next is physical dependence. Long-acting benzodiazepines, for example diazepam and chlordiazepoxide, are used to reduce the withdrawal symptoms of physical dependence associated with alcohol and long-term use of short-acting benzodiazepines and barbiturates. So what all are the uses of benzodiazepines? can be used for the treatment of anxiety, for sleep disorders, then for facilitating andrograde amnesia. The drug used is midazolam. Next, for the treatment of seizures, for alcohol withdrawal and reduce the risk of withdrawal related seizures. Then for muscular disorders, especially multiple sclerosis and cerebral palsy. Then physical dependence. Okay, so all these are the uses or therapeutic uses of benzodiazepines. Coming to the pharmacokinetics, the benzodiazepines are lipophilic. Lipophilic means lipid loving. We know that lipid loving agents can easily penetrate the central nervous system. Okay, central nervous system as well as the cell membrane, because cell membrane is made up of lipids. Okay, so the one of the most important property of benzodiazepines is that they are lipophilic in nature, so that they are rapidly and completely absorbed after oral administration, distribute throughout the body and penetrate into the CNS. Okay, so these benzodiazepines are lipophilic in nature and they can penetrate into the central nervous system. The onset of action is related to a relative degree of lipid solubility, which can vary 50-fold or more. Highly lipid soluble compounds such as midazolam, triazolam, diazepam have a rapid onset of action than relatively less lipid soluble benzodiazepines. Most benzodiazepines are available in oral dosage forms. Diazepam and midazolam can be given both parenterally and by the rectal route. Duration of action. This duration of action is very important in case of benzodiazepines. We have classified these benzodiazepines based on their duration of action. Okay, so the half-lives of the benzodiazepines are important clinically because the duration of action may determine the therapeutic usefulness. Based on this duration of action, we have seen in the classification that they are divided into short, intermediate and long-acting drugs. The long-acting agents form active metabolites with a long half-lives. However, with some benzodiazepines, the clinical duration of action does not correlate with the actual half-life. Otherwise, a dose of diazepam could conceivably be given only every other day given its long half-life and active metabolites. So this may be due to receptor dissociation rates in the CNS and subsequent redistribution to fatty tissues and other areas. That is, in simply we can say that there are some benzodiazepines, the clinical duration of action does not correlate with the actual half-life. An example is diazepam. Then short-acting benzodiazepines are more useful as they prevent pre-anesthetic anxiety and insomnia without causing hangover on awakening. Okay, we have seen one example which is midazolam, which is a short-acting benzodiazepine that is used to facilitate anterograde amnesia. Then long-acting benzodiazepines are generally more useful in managing anxiety, withdrawal states, seizures and insomnia. Next is the fate of benzodiazepines. Fate is nothing but the metabolism as well as excretion. Most benzodiazepines including chlordiazepoxide and diazepam are metabolized by phase 1 hepatic microsomal oxidation to compounds that are also active, which means this diazepam and chlordiazepoxide produce active metabolites after biotransformation or metabolism. So for these benzodiazepines, the apparent half-life of the drug represents the combined actions of the parent drug and its metabolites to as long as 60 hours or more, accounting for hangover and other cumulative effects when administered repeatedly. Chlordiazepate is a prodrug. It is hydrolyzed in the stomach. The benzodiazepines are excreted in the urine as glucuronides or oxidized metabolites. Short-acting and intermediate-acting benzodiazepines are biotransformed by hydroxylation. Example is estazolam and or direct glucuronidation. For example, lorazepam, oxazepam, temazepam to inactive metabolites followed by renal clearance. Okay, so we have seen that long-acting agents will produce active metabolites after biotransformation or metabolism, whereas this short-acting and intermediate-acting benzodiazepines, for example, estazolam, undergo biotransformation by hydroxylation, and drugs such as lorazepam, oxazepam and temazepam, they undergo direct glucuronidation. Direct glucuronidation means they does not require phase 1 metabolism. They will directly enter into the phase 2 metabolism, which is the direct glucuronidation, and they will form inactive metabolites, which is followed by renal clearance. Okay, so the clearance of benzodiazepines is reduced in the elderly and in patients with impaired hepatic function. Therefore, the dose should be reduced in these patients. Okay, so the dose adjustment should be done in elderly patients taking benzodiazepines. So all benzodiazepines cross the placenta and may depress the CNS of the newborn if given before birth. It is not recommended for use during pregnancy. Nursing infants may also be exposed to the drugs in the breast milk. Okay, so these benzodiazepines are contraindicated or contraindicated in pregnancy as well as breastfeeding. Benzodiazepines are controlled substances. Okay, so their use can result in tolerance, abuse as well as dependence. Tolerance develops to the sedative, hypnotic and anticonvulsant actions of benzodiazepines, though to a lesser extent to the anxiolytic action. So what do you mean by tolerance? Tolerance is the decreased responsiveness to repeated doses of the drug that occurs when used for more than 1 to 2 weeks. Okay, so tolerance is nothing but it is the decreased response to a particular dose of a drug if the particular drug is given as repeated dose and it is used for more than 1 to 2 weeks. And this tolerance develops mainly to the sedative, hypnotic and anticonvulsant actions of the benzodiazepines and to a lesser extent to the anxiolytic action. Then cross tolerance also occurs with other hypnotic and sedative agents including alcohol and barbiturates. Then psychological and physical dependence can develop if high doses of benzodiazepines are given for a prolonged period. All benzodiazepines are controlled substances. Then abrupt discontinuation of these agents results in withdrawal symptoms including confusion, anxiety, agitation, restlessness, insomnia, tension and rarely seizures. Okay, so these benzodiazepines should be stopped only gradually. Okay, abrupt discontinuation should not be done as these agents can result in withdrawal symptoms such as confusion, anxiety, agitation, restlessness, etc. Benzodiazepines with a short elimination half-life such as triazolam induce more abrupt and severe withdrawal reactions than those seen with drugs that are slowly eliminated such as flurazepam. The withdrawal reaction can be minimized by tapering the dose gradually or by substituting the long-acting benzodiazepines, for example, diazepam and chlordiazepoxide. Coming to the adverse effects of benzodiazepines, daytime drowsiness and sedation and confusion are the most common adverse effects of benzodiazepines. Then ataxia. Ataxia means poor muscle control. This ataxia occurs at high doses and precludes activities that require fine motor coordination, particularly in the elderly and with a long-acting benzodiazepines. And next is cognitive impairment. It is the decreased recall and retention of new knowledge, especially in the elderly patients. Then these benzodiazepines should be used cautiously in patients with a liver disease. Then respiratory depression at higher doses than hypnotic doses. Then alcohol and other CNS depressants enhance the sedative hypnotic effects of the benzodiazepines. Okay, so these benzodiazepines should not be used with alcohol and other CNS depressants. These benzodiazepines are considerably less dangerous than other older anxiolytic and hypnotic drugs. Then when administered by the parenteral route may cause hypotension and bradycardia in patients with impaired cardiovascular function. Then CYP3A4 enzyme inhibitors and grapefruit juice can extend the duration of action of benzodiazepines. Okay, so the most important adverse effects are daytime drowsiness, sedation and confusion, then ataxia. Ataxia means poor muscle control, then cognitive impairment, then respiratory depression at higher doses than the hypnotic doses. Then the points to remember is that benzodiazepines should be used cautiously in patients with liver disease. Then these benzodiazepines have drug interaction with the alcohol and other CNS depressant drugs. Okay, they may enhance the sedative hypnotic effects of benzodiazepines. So these drugs should not be used together. Then these benzodiazepines might have interaction with the CYP3A4 enzyme inhibitors and grapefruit juice as they can extend the duration of action of benzodiazepines. Next is the benzodiazepine antagonist. The drug is called Flumazenil. It is a competitive GABA receptor antagonist that rapidly reverses the effects of benzodiazepines. It is available as intravenous administration only. Flumazenil has got a rapid onset of action, but the duration is short with a half-life of about 1 hour. Accidental ingestion of benzodiazepines is treated with supportive care, emetics and/or activated charcoal. Frequent administration may be necessary in patients with marked central nervous system depression to maintain reversal of a long-acting benzodiazepine. Administration of flumazenil may precipitate withdrawal in dependent patients or cause seizures if a benzodiazepine is used to control seizure activity. Seizures may also result if the patient has a mixed ingestion with a tricyclic antidepressants or antipsychotics. So the dizziness, nausea, vomiting and agitation are the most common adverse effects. So the benzodiazepine antagonist is Flumazenil. It is available as intravenous administration only. So we have completed benzodiazepines. Now let's have a discussion about other anxiolytic agents. So the first one, antidepressants. Many antidepressants are effective in the treatment of chronic anxiety disorders and should be considered as first-line agents, especially in patients with concerns for addiction or dependence. So we have already discussed that the benzodiazepines are controlled substances. Okay, so because of this property, they have got this abuse potential as well as the development of tolerance as well as dependence. Okay, so because of these concerns, many antidepressants are nowadays effective in the treatment of chronic anxiety disorders. So among them, selective serotonin reuptake inhibitors, that is SSRIs such as escitalopram or paroxetine, or SNRIs, that is serotonin norepinephrine reuptake inhibitors such as venlafaxine or duloxetine, may be used alone or prescribed in combination with a benzodiazepine during the first weeks of treatment. So among these antidepressants, SSRIs such as escitalopram or paroxetine, or SNRIs, that is serotonin norepinephrine reuptake inhibitors such as venlafaxine or duloxetine, can be used as anxiolytic agents. After 4 to 6 weeks, when the antidepressant begins to produce an anxiolytic effect, the benzodiazepine dose can be tapered. While only certain SSRIs or SNRIs have been approved for the treatment of anxiety disorders such as generalized anxiety disorder, the efficacy of these drugs is most likely a class effect. Long-term use of antidepressants and benzodiazepines for anxiety disorders is often required to maintain ongoing benefit and prevent relapse. Next drug is Buspirone. It is a non-benzodiazepine partial agonist at serotonin receptors. The actions of Buspirone appear to be mediated by serotonin receptors, that is 5-HT1A, although it also displays some affinity for dopamine receptors, that is D2, and 5-HT2A serotonin receptors. Thus, its mode of action differs from that of the benzodiazepines. This Buspirone is useful for the chronic treatment of generalized anxiety disorder and has an efficacy comparable to that of benzodiazepines, as it is devoid of sedation, hypnosis, and general CNS depression or drug abuse liability of benzodiazepines. It has a slow onset of action and is not effective for short-term or as needed treatment of acute anxiety. In addition, Buspirone lacks the anticonvulsant and muscle relaxant properties of the benzodiazepines. So if we compare this Buspirone and benzodiazepines, the advantage of this Buspirone over benzodiazepines is that this Buspirone is devoid of sedation, hypnosis, and general CNS depression or drug abuse liability of benzodiazepines. Coming to the disadvantages, this Buspirone has got a slow onset of action and is not effective for short-term or as needed treatment of acute anxiety. Also, this Buspirone lacks the anticonvulsant and muscle relaxant properties of the benzodiazepines. Buspirone usually requires therapy of 3 to 6 weeks to demonstrate efficacy. Then adverse effects are comparatively low, with the most common effects being headache, dizziness, nervousness, nausea, and lightheadedness. Sedation and psychomotor and cognitive dysfunction are minimal and dependence is unlikely. So it is a benefit that is particularly important in elderly patients. Buspirone does not potentiate the CNS depression of alcohol. So next we are going to learn about barbiturates. The barbiturates were formerly the mainstay of treatment to sedate patients or to induce and maintain sleep. They have been largely replaced by the benzodiazepines, primarily because barbiturates induce tolerance and physical dependence and are lethal in overdose and are associated with severe withdrawal symptoms. So, as like this benzodiazepines, all barbiturates are controlled substances. Now coming to the mechanism of action, the sedative hypnotic action of the barbiturates is due to their interaction with GABA A receptors, which enhances GABAergic transmission. So we have already discussed that GABA is an inhibitory neurotransmitter. So what this GABA normally will do? The GABA will bind to its receptor that will lead to opening of the chloride ion channel. As a result, hyperpolarization of the neuron, and thereby it reduces the neuronal excitability. So this barbiturates, the binding site of barbiturates on the GABA receptor is distinct from that of the benzodiazepines. So the barbiturates potentiate GABA action on chloride entry into the neuron by prolonging the duration of the chloride channel openings. So we have seen that the mechanism of action of benzodiazepines is that they will potentiate GABA action by increasing the frequency of chloride channel opening. So what this barbiturates will do? This barbiturates will also potentiate GABA action by prolonging the duration of action of chloride channel openings. Okay, so this barbiturates will potentiate GABA action by prolonging the duration of chloride channel opening, or else we can say that it will increase the lifetime of chloride channel opening induced by GABA. In addition, barbiturates can block excitatory glutamate receptors. These molecular actions led to decreased neuronal activity. Okay, so this is a mechanism of action of barbiturates. Both these benzodiazepines as well as barbiturates potentiate the GABA action. But these benzodiazepines potentiate the GABA action by increasing the frequency of chloride channel opening, whereas these barbiturates potentiate the GABA action by increase the lifetime of chloride channel opening induced by GABA. Pharmacological actions of barbiturates. The first one is depression of CNS. At low doses, the barbiturates produce sedation, that is having a calming effect and reduce excitement. At higher doses, the drugs causes hypnosis followed by anesthesia, that is loss of feeling or sensation, and finally coma and death. Thus, any degree of depression of the CNS is possible depending on the dose. That is, at low doses, the barbiturates produce sedation, whereas at higher doses, the barbiturates can cause hypnosis followed by anesthesia, finally coma and death. Barbiturates do not raise the pain threshold and have no analgesic properties. They may even exacerbate pain. Chronic use leads to tolerance. And next is respiratory depression. These barbiturates suppress the hypoxic and chemoreceptor response to carbon dioxide, and overdose is followed by respiratory depression and death. Okay, so the two major pharmacological actions of barbiturates is that CNS depression as well as respiratory depression. Moving on to the therapeutic uses, the first use is anesthesia. The ultra short-acting barbiturates, the examples of ultra short-acting barbiturates are thiopental and methotrexate. So these ultra short-acting barbiturates have been historically used intravenously to induce anesthesia but have been replaced by other agents. So these ultra short-acting barbiturates can be used as intravenous anesthetics. So the second use is anticonvulsant action. Phenobarbital has specific anticonvulsant activity that is distinguished from the non-specific CNS depression. It should be used for seizures only if other therapies have failed. Similarly, phenobarbital may be used for the treatment of refractory status epilepticus. Next use is sedative or hypnotic. Barbiturates have been used as mild sedatives to relieve anxiety, nervous tension, and insomnia. When used as hypnotics, they suppress rapid eye movement, that is the REM sleep, more than other stages. Use of barbiturates for insomnia is no longer generally accepted given their adverse effects and potential for tolerance. Butalbital is commonly used in combination products with acetaminophen and caffeine or aspirin and caffeine as a sedative to assist in the management of tension or migraine headaches. So the three most important therapeutic uses of barbiturates include anesthesia, especially these ultra short-acting barbiturates are used as IV anesthetics. Next is anticonvulsant action. Mainly used drug is phenobarbital. It should be used only for seizures only if other therapies have failed, and also it may be used for treatment of refractory status epileptics. Then these barbiturates can also be used as sedative as well as hypnotics. Moving on to the pharmacokinetics, barbiturates are well absorbed after oral administration and distribute throughout the body. All barbiturates redistribute from the brain to the splanchnic areas to skeletal muscle and finally to the adipose tissue. Barbiturates readily cross the placenta and can depress the fetus, hence it is contraindicated in pregnancy. These agents are metabolized in the liver and inactive metabolites are excreted in urine. Moving on to the adverse effects, mainly include drowsiness, impaired concentration and mental and psychomotor impairment. Then the CNS depressant effects of barbiturates synergize with those of ethanol. Then hypnotic doses of barbiturates will produce a drug hangover effect. Occasionally, nausea and dizziness can occur. Then one of the most important property of these barbiturates is that they are cytochrome P450 enzyme inducers. What these enzyme inducers will do? They will increase the metabolism of the drugs that are metabolized by this particular cytochrome P450 enzyme system. So that will lead to therapeutic failure. So this phenobarbital or these barbiturates are cytochrome P450 enzyme inducer. Therefore, chronic barbiturate administration diminishes the action of many drugs that are metabolized by the cytochrome P450 system. Then one more point is that barbiturates are contraindicated in patients with acute intermittent porphyria. What is this acute intermittent porphyria? It is a genetic disorder, metabolite affecting the production of heme. So what is this porphyrin? Porphyrin is a metabolite of hemoglobin. These barbiturates will increase the synthesis of porphyrins. Okay, so hence these barbiturates are contraindicated in patients with acute intermittent porphyria. Then abrupt withdrawal may cause tremors, anxiety, weakness, restlessness, nausea and vomiting, seizures, delirium, and cardiac arrest. Withdrawal is much more severe than that associated with opioids and can result in death. Severe depression of respiration and central cardiovascular depression results in a shock-like condition with shallow, infrequent breathing. Treatment includes supportive care and gastric decontamination for recent injections. So the main points to be noted down here is that barbiturates are cytochrome P450 enzyme inducers. So it will cause increased metabolism of the co-administered drugs, and also it is contraindicated in patients with acute intermittent porphyria. And the withdrawal is more severe than that associated with opioids and can result in death. So there should not be abrupt withdrawal. Withdrawal should be only gradual. Okay, so far we have discussed about benzodiazepines as well as barbiturates. So at high concentrations, barbiturates directly increase the chloride conductance, that is GABA mimetic action. That is, these barbiturates have GABA mimetic action. In contrast, benzodiazepines have only GABA facilitatory action. This is also one important difference between benzodiazepines as well as barbiturates. These barbiturates have GABA mimetic action, whereas these benzodiazepines have only GABA facilitatory action. Okay, so now let's discuss about the next class of drugs, that is the non-benzodiazepine hypnotic agents. Mainly includes this SED drugs. Okay, they are often referred to as SED drugs, are similar to benzodiazepine in nature, though they are unrelated to benzodiazepines on a molecular level as they have dissimilar or entirely different chemical structures. However, the pharmacodynamics of non-benzodiazepine is almost entirely the same as that of benzodiazepine and therefore employs similar benefits, adverse effects, and risks. Like the benzodiazepines, non-benzodiazepines exert their effects by binding to and activating the benzodiazepine site of the receptor complex. Their actions are blocked and reversed by the benzodiazepine antagonist Flumazenil, widely used for short-term management of insomnia. So these non-benzodiazepine hypnotic agents are widely used for short-term management of insomnia. Unlike the benzodiazepines at usual hypnotic doses, the non-benzodiazepine drugs, examples including solpidem, salipilone, and esopiclone, do not significantly alter the various sleep stages and hence are often the preferred hypnotics. So the main advantage of this non-benzodiazepine hypnotic agents is that unlike these benzodiazepines at usual hypnotic doses, these non-benzodiazepine drugs do not alter the various sleep stages. Okay, hence they are often the preferred hypnotics. All the three agents are controlled substances. Reduced potential for tolerance, abuse, physical dependence, or rebound insomnia. Okay, so these are some advantages of non-benzodiazepine hypnotic agents over benzodiazepines. They are widely used for the short-term management of insomnia and they do not significantly alter the various sleep stages. Also, they are controlled substances and they have got only reduced potential for tolerance, abuse, physical dependence, or rebound insomnia. Okay, so the first drug is solpidem that comes under newer non-benzodiazepine hypnotics. The hypnotic solpidem is not structurally related to benzodiazepines, but it binds to GABA A receptor, okay, with relative selectivity for those with the alpha 1 subunit. It has no anticonvulsant or muscle relaxing properties at a hypnotic doses. It shows few withdrawal effects, exhibits minimal rebound insomnia, and little tolerance occurs with a prolonged use. Rapidly absorbed after oral administration, it has got a rapid onset of action and short elimination half-life. Rapid onset in the sense, what do you mean by onset? It is a time at which a particular drug produces its action. So the solpidem has got a rapid onset of action and a short elimination half-life. Short elimination half-life means half-life is about 2 to 3 hours. The drug provides a hypnotic effect for approximately 5 hours. That is, the duration of action is 5 hours. A lingual spray and an extended release formulation are also available. A sublingual tablet formulation may be used for middle of the night awakening. Then the solpidem undergoes hepatic oxidation by the cytochrome P450 system to inactive products. Thus, drugs such as rifampin, which induces enzyme system, shorten the half-life of solpidem, and drugs that inhibit the CYP3A4 isoenzyme may increase the half-life. Okay, so the solpidem has got drug interactions if enzyme inducers or enzyme inhibitors are co-administered. Then adverse effects include headache, dizziness, anterograde amnesia, and next morning impairment. This next morning impairment is especially with the extended release formulations. Then sleepwalking, sleep driving, and performing other activities while not fully awake have been reported. Next drug is Salipron. It is an oral non-benzodiazepine hypnotic similar to Solpidem. Salipron causes fewer residual effects on psychomotor and cognitive function compared to Solpidem or the benzodiazepines. This may be due to its rapid elimination with a half-life of approximately 1 hour. The drug is metabolized by CYP3A4. Next drug is Esopiclone. It is also an oral non-benzodiazepine hypnotic that has been shown to be effective for insomnia for up to 6 months. Therefore, unlike both Solpidem and Salipron, its use is not restricted to short-term use. Esopiclone is rapidly absorbed, that is time to peak is 1 hour, extensively metabolized by oxidation and demethylation via the cytochrome P450 system to inactive metabolites and mainly excreted in urine. Elimination half-life is approximately 6 hours. Esopiclone is well tolerated. The main adverse events associated with esopiclone include unpleasant taste, anxiety, dry mouth, headache, peripheral edema, and somnolence. Okay, so the half-life of saliplone is approximately 1 hour and esopiclone elimination half-life is approximately 6 hours. And the peculiarity of this esopiclone is that it is effective for insomnia for up to 6 months. Therefore, its use is not restricted to short-term use. Other hypnotic agents. So the first class is melatonin and melatonin receptor agonists. So what is this melatonin? It is a hormone secreted by the pineal gland that helps to maintain the circadian rhythm underlying the normal sleep-wake cycle. Okay, so this melatonin is a hormone secreted by the pineal gland to maintain the circadian rhythm. At an oral dose of 80 mg, melatonin induces sleep. But at lower doses of 2 to 10 mg, it slightly induces the propensity to fall asleep without CNS depression. Therefore, it is used to treat jet lag in international travelers and to counter the disturbance in the sleep cycle in night workers. Ramelton and tacimelton are selective agonists at the MT1 and MT2 subtypes of melatonin receptors involved in promotion of sleep. Stimulation of MT1 and MT2 receptors by Ramelton and tacimelton is thought to induce and promote sleep. They have minimal potential for abuse and no evidence of dependence or withdrawal effects have been observed. Therefore, Ramelton and tacimelton can be administered long term. Okay, so the advantages of this melatonin receptor agonist include they have minimal potential for abuse and there is no evidence of dependence or withdrawal effects. So because of these advantages, this Ramelton and tacimelton can be administered for long term. Cytochrome P450, that is CYP1A2 and CYP3A4 are the principal isoenzymes required for the metabolism of Ramelton and tacimelton, and thus drug-drug interactions are possible with enzyme inducers or inhibitors of these particular enzymes. So Ramelton, it is a melatonin receptor agonist. It is indicated for the treatment of insomnia characterized by difficulty falling asleep, that is increased sleep latency. Common adverse effects of Ramelton include dizziness, fatigue and somnolence. Ramelton may also increase prolactin levels. Next one is tacimelton. It is indicated for non-24-hour sleep-wake disorder, often experienced by patients who are blind. The most common adverse effects of tacimelton are headache, abnormal dreams, increase in liver function test and possible upper respiratory tract infections. Okay, so the two melatonin receptor agonists are Ramelton and tacimelton. Ramelton is metabolized by CYP1A2. It is used for the treatment of insomnia characterized by difficulty falling asleep, and it may also increase prolactin levels. Next one is tacimelton. It is metabolized by CYP3A4 isoenzyme. It is used for the treatment of non-24-hour sleep-wake disorder, for example, in case of blind patients. Okay. Antihistamines. We all are familiar about antihistamines. So some antihistamines with sedating properties such as diphenhydramine, hydroxyzine and doxylamine are effective in treating mild types of situational insomnia. We know that antihistamines can be classified into two generations, that is first generation as well as second generation. First generation, their major side effect is sedation. Okay, so antihistamines with sedating properties, for example diphenhydramine, hydroxyzine and doxylamine are effective in treating mild types of situational insomnia. However, they have undesirable adverse effects such as anticholinergic effects that make them less useful than the benzodiazepines and the non-benzodiazepines. Sedative antihistamines are marketed in numerous over-the-counter products. Okay, so next one is antidepressants. Among the antidepressants, doxepin, which is an older tricyclic agent with SNRI, that is serotonin norepinephrine reuptake inhibitor mechanisms of antidepressant and anxiolytic action, is approved at low doses for the management of insomnia. Other antidepressants such as trazodone, mirtazapine and other tricyclic antidepressants with strong antihistamine properties are used off-label for the treatment of insomnia. So there's certain antihistamines having sedative properties as well as antidepressants such as doxepin, then trazodone, mirtazapine and certain other older tricyclic antidepressants can be used for the treatment of insomnia. Okay, so the last drug that comes under this class is suvorexant. It is an antagonist of the orexin receptor. Orexin is a neuropeptide that promotes wakefulness. So the antagonism of the effects of orexin suppresses the wake drive from this neuropeptide. So the suvorexant is an antagonist of the orexin receptor. What this orexin will do? It promotes wakefulness. Okay, so the suvorexant, by antagonizing this orexin receptor, it will promote sleep. This antagonism may also explain the adverse events that are similar to signs of narcolepsy and cataplexy. The loss of orexin producing neurons is believed to be an underlying pathology for narcolepsy. Daytime somnolence and increased suicidal ideation are other reported adverse effects. Suvorexant is mainly metabolized by cytochrome P450 isoenzyme, which is CYP3A4, and thus it may have drug interactions with CYP3A4 inducers or inhibitors. Okay, so we have completed this chapter. So under this chapter we have discussed the most important drugs, that is benzodiazepines as well as barbiturates, then melatonin receptor agonist, then other drugs that can be used as anti-anxiety drugs as well as sedatives and hypnotics. So if you require further information or further details, you can refer Lippincott textbook of pharmacology. Okay, so thank you for watching this video. If you have any doubts, you can mention in the comment section. Okay, so have a nice day.